Bismillahirrahmanirrahim. Assalamu alaikum. Greetings from my institute. In the previous vlog, we discussed functional dyspepsia in detail. In today's discussion, we will explore the role of prokinetics in the management of functional dyspepsia. Just a brief review of the definition and subtypes of functional dyspepsia, which we discussed in detail in our previous vlog. Functional dyspepsia is defined as chronic dyspeptic symptoms without an identifiable structural cause, an upper GI endoscopy. According to Room 4 criteria, it has got two subtypes. First, postprandial distress syndrome, which is characterized by early satiety with post-meal fullness. And the second subtype is epigastric pain syndrome, which is characterized by epigastric pain or burning unrelated to meals. Let's start with the mechanism of action of different prokinetics. The topmost are the most common 6 prokinetics: Acotiamide, domperidone, metoclopramide, mosapride, prokinetic, and Itopride. The acotiamide, it acts through inhibiting acetylcholinesterase enzyme. So its mechanism of action is acetylcholinesterase inhibition, and it enhances gastric motility and accommodation. The second prokinetic, domperidone, it's dopamine D2 receptor antagonist, and it increases acetylcholinesterase release. So it increases the acetylcholine release. Then the metoclopramide, it's D2 antagonist and weak 5H4 agonist, and it acts as prokinetics and antiemetic. Then the mosapride, it's 5H4 agonist, and it enhances gastric motility. Then prokinetic, it's 5H4 agonist, and it increases peristalsis. Then the Itopride, it's a D2 antagonist as well as acetylcholinesterase inhibitor. So the prokinetics highlighted in green, that is acotiamide, the domperidone, mosapride, and prokinetic, they have one mechanism of action. The acotiamide, it's acetylcholinesterase inhibitor. The domperidone, it's dopamine D2 receptor antagonist, while mosapride and prokinetic, it is 5H4 agonists. While the two, the metoclopramide and Itopride, I have highlighted them, I have shaded them red, and they have two mechanisms of actions. For example, metoclopramide is D2 antagonist as well as weak 5H4 agonist. Similarly, Itopride is D2 antagonist plus acetylcholinesterase inhibitor. So what are the indications for prokinetics? Acotiamide is indicated in functional dyspepsia of PDS type, as well as it is being used off-label for gastroparesis. Domperidone is indicated in gastroparesis, nausea, gastroesophageal reflux disease, as well as functional dyspepsia. While metoclopramide is indicated in gastroparesis, nausea, and GERD, just like domperidone. Mosapride is indicated in functional dyspepsia, the GERD, as well as the gastroparesis. The Prokinetic has been used and indicated in chronic constipation and gastroparesis, while Itopride is indicated in functional dyspepsia as well as gastroparesis. What's the dose? What are the dosing of these prokinetics? Acotiamide dose is 100 milligram 3 times a day before meals. The domperidone dose is 10 milligram 3 times a day before meals. The metoclopramide dose is 5 to 10 milligram 3 times a day before meals. The mosapride dose is 5 milligram 3 times a day before meals. Prokinetic is given OD dose of 2 milligram and Itopride is given 50 milligram 3 times a day before meals. What are the adverse effects? The adverse effects of Acotiamide are mild GI upset and rare hepatotoxicity. Adverse effects of domperidone include QT prolongation and hyperprolactinemia. Adverse effects of metoclopramide include extrapyramidal side effects, rather it is notorious for this, and tardive dyskinesias. The adverse effects of mosapride include diarrhea and abdominal pain, while adverse effects of prokinetic include headache and diarrhea. Similarly, adverse effects of Itopride are GI upsets and QT prolongation, which is a rare one. What are the key advantages of different prokinetics? The key advantage of Acotiamide is there is no dopamine antagonism, so no extra pyramidal effects, and it is effective in functional dyspepsia of PDS subtype. The key advantage of domperidone is that it's good for nausea and vomiting, and it has got less CNS penetration than metoclopramide, so less CNS effects. The key advantage of metoclopramide is that it's the strongest anti-emetic effect among all prokinetics. Similarly, key advantage of mosapride is it has got no dopamine antagonism and it has got fewer CNS effects. The key advantages of prokinetic are that it's highly effective for constipation-related motility issues. And the key advantage of Itopride is that it has got dual mechanism and lower CNS penetration. What are the key disadvantages of these prokinetics? The key disadvantage of Acotiamide is it's not widely available in some regions, but luckily here in Pakistan it is available. Then the key disadvantage of dopamine is cardiac concerns, that is the QT prolongation and prolactin related effects. Similarly, the key disadvantage of metoclopramide is high risk of CNS side effects with long-term use. The key disadvantage of mosapride is that it's less effective for nausea. Similarly, the limited efficacy in upper GI disorders of prokinetic is its key disadvantage. While the Itopride again has a limited global availability and this becomes its key disadvantage, but this is available in Pakistan. So, how we can select the prokinetics by the condition? In the functional dyspepsia PDS type, the best prokinetic is Acotiamide and alternative is mosapride. Similarly, in gastroparesis with nausea and vomiting, the best prokinetic is metoclopramide in short-term use and domperidone is an alternative and for long-term use. While functional dyspepsia with reflux and constipation, the best prokinetic is mosapride and alternative is prokinetic. Similarly, chronic constipation with delayed gastric emptying, The best prokinetic is Prokinetic and alternative is Itopride. And now there is meta-analysis, and the meta-analysis systemic review does show that the total efficacy rate is better in prokinetics as compared to placebo, and this is all the Acotiamide, Itopride, domperidone, Itopride, metoclopramide, musapride, all has been found to be effective. Similarly, the drug-related adverse events rate with Itopride, domperidone, Acotiamide compared with placebo, they are not that heavy side effects are serious as compared to placebo. So the best choice by condition remains functional dyspepsia, PDS type, Acotiamide, gastroparesis, in short-term metoclopramide, and in long-term alternative domperidone. Then functional dyspepsia with predominant reflux, musapride is the best option. And functional dyspepsia with predominant constipation, Prokinetic. So the key takeaways from today's discussion is Acotiamide is unique in functional dyspepsia because it targets gastric accommodation, whereas most others primarily enhance motility. Then metoclopramide and domperidone are better for nausea, vomiting, but have dopamine-related side effects. Similarly, musapride and Prokinetic are good motility enhancers, but their effects on gastric accommodation are limited. And Itopride is similar to Acotiamide, but has dopamine antagonism, leading to potential CNS side effects. So with this, I pay thanks for you to be with me in today's discussion. I hope I was clear in explaining the different prokinetics, their role in functional dyspepsia, their mechanisms of actions, their key advantages and disadvantages, and the best option for different types of functional dyspepsia. I end here. Inshallah, in the next vlog, we shall discuss the role of Acotiamide in functional dyspepsia. Till then, take care. Khuda Hafiz.